Hello, thank you for joining us. My name is Mukta Srivastava. I'm an assistant professor of medicine at the University of Maryland School of Medicine and an interventional cardiologist, and I'm the program director for the cardiovascular disease training program at the medical center. And today I'd like to discuss left atrial appendage occlusion, some of the newer technologies in this arena, specifically the WATCHMAN device. And so my talk is entitled WATCHMAN or Watch and Wait. I have no disclosures. And some of the questions that we'd like to answer in this session are, what are the long-term risks of stroke without or anticoagulant or antiplatelet therapy in atrial fibrillation? What is the efficacy of left atrial appendage occlusion in reducing this AFib-associated stroke risk? What are the peri-procedural and long-term risks of left atrial appendage occlusion? And what is the cost efficacy of I want to start with some background. As we know, the disease burden of AFib is very strong. There are 5 million patients with AFib in the United States, and that number is projected to increase to 15 million by the year 2050. This disease burden is also associated with a large cost component, with about $16 billion dedicated to AFib therapy in the United States annually. We also know that 15 to 20% of all strokes are related to AFib, and that morbidity and mortality are higher in strokes that are associated with atrial fibrillation. The paradox of this is that 40% of patients eligible for anticoagulation therapy, which is the mainstay of therapy to reduce stroke risk in AFib, are not treated. And this is a result of concrete contraindications to anticoagulation therapy, such as intracranial bleeds, urologic bleeds, and GI bleeding, as well as elevated perceived risk of anticoagulation therapy in the populations that are most vulnerable. 50 to 60% of patients who are treated with Coumadin also are not in therapeutic range, even though they are on therapy. And so this has led to a focus on alternative mechanisms of capturing this at-risk population, recognizing that 90% of all emboli that are responsible for thromboembolic events in AFib patients originate from the left atrial appendage. And so potentially targeting this structure may be another target for therapy in this population. This is a graph from a Mayo Clinic Proceedings article that looks at adherence to medical therapies in patients who have had an ischemic stroke in the first 24 months past their event. And notably, there's a significant drop-off in adherence to all guideline recommended therapies, but most significantly, the drop-off is in adherence to Coumadin therapy. This is a little bit more of a complex chart, and the end message of this chart is that despite a perceived risk of elevated risk in treating patients with anticoagulation therapy, in almost all range of patients in terms of their bleeding risk and their embolic risk, anticoagulation therapy is almost always superior to no therapy. And so on this axis we have the risk of embolic stroke, and on this axis we have the risk for intracranial bleeding. And in this graphic that's taken from a large Swedish cohort of over 180,000 patients, they found that despite having very elevated risk and lower stroke risk, even patients in this grouping had a high risk of events off of anticoagulation compared with being treated with anticoagulation. There are several considerations as to why the left atrial appendage is an area to target in reducing stroke risk. The left atrial appendage has an anatomy that's shown here that really predisposes to thrombus. There's a narrow orifice, and there's a trabeculated structure with stasis of blood flow that predisposes to pooling of blood and formation of thrombus. The concept that exclusion of the left atrial appendage may be beneficial in treating stroke risk dates back even to the 1930s. This is an article from JAMA from 1949 in which Dr. John Madden, a surgeon from New York, published a case series of patients on whom he operated to resect the left auricular appendix in an effort to reduce recurrent arterial emboli. What we've learned over the years is that there are some limitations to surgical left atrial appendage exclusion. There's variable success with thrombus noted in 50% of incompletely ligated left atrial appendages that was noted in one series that looked at these patients in follow-up with TEE imaging. Some of the reasons that surgical exclusion is not successful is that the left atrial appendage anatomy is altered when patients are under cardiopulmonary bypass, so landmarks are difficult to identify in terms of oversewing the appendage appropriately at the orifice. There's also some hesitation in aggressive oversewing because of the proximity of this structure to the circumflex artery. Most effectively, surgical appendage ligation is performed as part of the Cox-Maze procedure, in which it is both oversewn and then excised, and this has been most effective way of surgically excluding the left atrial appendage. This is an example of an oversewn appendage. The aortic valve is visualized here, and here's the appendage, and there is dehiscence of the oversewn material so that you can see blood flow entering the left atrial appendage after surgical exclusion. These limitations then led to the concept that potentially we could accomplish left atrial appendage exclusion percutaneously while the patient is not on bypass. There are several technologies that are in development, in different phases of development for accomplishing percutaneous LAAO. The WATCHMAN device is the most rigorously studied device and is currently FDA approved. The Lariat device is also FDA approved but not studied in randomized trials. The Amplatzer cardiac plug is currently undergoing randomized trials in the US, and the WaveCrest device is an additional therapy in the pipeline. And I will focus mostly on the WATCHMAN device. The WATCHMAN device is pictured here. It's a self-expanding nitinol cage with distal fixation barbs, and this is the distal end of the device. The proximal end is coated with a PTFE fabric, which has 160 micron membrane, which promotes endothelialization when the device is implanted. The device is placed with TEE guidance into the orifice of the left atrial appendage. It's shown in its deployed configuration here. The fixation barbs are distal, and there's 10 fixation anchors here, which stabilize its position at the orifice of the left atrial appendage. The PTFE membrane side faces the left atrium and promotes endothelialization, and this is placed through percutaneous transeptal access into the left atrial appendage. This is a pathologic specimen, unfortunately post-mortem, in a patient who has had a WATCHMAN device placed, and you can see that the surface of the device is completely endothelialized. I will dedicate some time to looking at the trials that evaluated the WATCHMAN device and sort of the trajectory that took the device from trial data to FDA approval. The WATCHMAN has been studied in 2 randomized trials, the PROTECT-AF and the PREVAIL trials. Each of those trials have an extended registry, the CAP and CAP2 registries. Additionally, the device has been studied in Europe as part of the Evolute registry. We have post-approval data from post-FDA approval in the US, and finally, the device has been studied as part of the non-randomized ASAP and the currently enrolling ASAP-2 trial. PROTECT-AF was a significant trial because this was the first randomized trial, the first significant experience worldwide evaluating endovascular left atrial appendage closure and comparing that to medical therapy. This randomized trial was conducted at 59 centers in the US and Europe. The enrollment occurred 2005 through 2009, and they randomized 700 patients in a 2-to-1 fashion to device therapy or medical therapy. And currently, to date, we have 3.8 years of follow-up that has been published. And the endpoints that were evaluated included stroke, ischemic or hemorrhagic, thromboembolic events, cardiovascular mortality, and all-cause mortality. There was also a primary safety endpoint, and this looked at procedure-related events of pericardial effusion, stroke, and device embolization, and major bleeding. Here are two Kaplan-Meier curves from this trial, and what we see is that the device is shown in green and then warfarin is in red. And for the primary efficacy endpoint, the probability of an event was higher in the warfarin arm at follow-up, and you see the curves diverging. And so the device was non-inferior to Coumadin therapy. For all-cause mortality, again, early in follow-up, there's non-inferiority of the device, and over time these curves diverge so that at 3.8-year follow-up, the WATCHMAN device is actually superior to Coumadin therapy for cardiovascular mortality and all-cause mortality. So the first FDA panel was convened in 2009 for approval of this device based on the findings of the PROTECT-AF trial, and actually the device was not approved at that time. The panel cited concerns over the safety profile of the device. They also pointed out that the CHADS-2 score of the patients enrolled in this trial, 30% of them was only a CHADS score of 1, which made it questionable if they would benefit from undergoing an invasive procedure to reduce their stroke risk. And additionally, there was concomitant use of antiplatelet agents in the device arm because some of these patients did have other indications for antiplatelet therapy. So the FDA collaborated with the device sponsors to design the PREVAIL trial, which is now the second randomized trial of this device. This device, this trial enrolled at 41 US sites, and one of the stipulations was that 25% of the operators in this trial would be new operators to really demonstrate that the device could be safely implanted, and new operators could be trained to be proficient at implanting the device. They had a higher CHADS-2 score requirement, and there was an exclusion for patients who were on chronic Plavix therapy. So what we have seen very beautifully through the series of trials studying the WATCHMAN device is the improvements in the safety profile that can be accomplished through a systematic approach. The device sponsors broached this from several angles. They improved the training program for operators. They made modifications to the actual device to reduce device embolization, and they made changes to the technique of deployment to reduce left atrial appendage laceration. And what we saw very successfully is that compared to a 9.9% rate of safety events in the first trial, throughout the second half of the PROTECT-AF trial, they already saw a reduction in significant safety events. And in the PREVAIL trial, which had 50% new operators, they had a significantly lower risk of safety events. And notably, many of these safety events were pericardial effusions, which are considered self-limited events. Nearly none of them were fatal events. And what we see in the evolution registry, which is the European registry, that the rate of safety events is significantly lower. A couple notable items from the WATCHMAN trials. Predominantly, these trials have enrolled Caucasian patients. In PROTECT-AF, 91%, 94% in PREVAIL, and in their registries, the pattern is similar. You do note that the CHADS score is higher in PREVAIL compared to PROTECT-AF, as mandated in the inclusion criteria, and the majority of these patients fell into a moderate risk category in terms of their has-bled risk score. The implant success rate has also seen incremental improvements. PROTECT-AF, the implant success rate was 91%. In the U.S. commercial experience post-FDA approval, the implant success rate is 96%. And success has been defined as successful deployment into the left atrial appendage with less than a 5 millimeter peri-device leak noted by TEE. So the PREVAIL trial, to look at this a little bit more closely, this was also a non-inferiority trial. 407 patients were enrolled for 18-month follow-up, and this was a more complex trial. There were 3 co-primary endpoints. The first one was simply the rate of adverse events regarding stroke, systemic embolism, and death. The second co-primary endpoint was late stroke, systemic embolism, or death, defined as 7 days after the implant. So the goal of this endpoint was to look at events outside of peri-procedural events, to really evaluate the device versus Coumadin therapy if you could get to a point where the device implant was completely safe. And 3 was an early safety endpoint looking at complications within 1 week of implant. And this is a Kaplan-Meier curve looking at that primary endpoint, the first primary endpoint of stroke, death, or systemic embolism, comparing the two devices. And what you see is that in absolute terms, the two curves are very similar, but over time they do diverge. And ultimately, statistically, the device per that first primary endpoint was not found to be non-inferior to Coumadin therapy. So a second FDA panel was convened in December of 2013. This was now looking at the device after 2 randomized trials. And once again, the device did not obtain FDA approval. The panel was split 13-1. The concerns were the divergence in that first primary endpoint between the control and device groups. So the first co-primary endpoint was not met, but the second and third were met in the PREVAIL trial. So moving forward, the device team collated a meta-analysis of the PROTECT-AF and PREVAIL trials. And in this meta-analysis, essentially, efficacy favored the WATCHMAN device. All stroke was sort of a neutral finding, and that's because ischemic stroke favored Coumadin, but hemorrhagic stroke favored the WATCHMAN device. But cardiovascular or unexplained death, all-cause mortality, and major bleeding all favored the WATCHMAN device. And how some of the proponents of the WATCHMAN device have explained the findings of the PREVAIL trial, looking at the stroke rates in the Coumadin arms of these large landmark trials, RELY, ROCKET-AF, Aristotle, and ENGAGE. These were the 4 trials that compared the new oral anticoagulation agents with Coumadin for AFib. The stroke rates in all these trials were fairly steady at 1 to 1.25%, and their mean CHAD scores are listed here. But somewhat paradoxically, in the Coumadin arm of the PREVAIL trial, the ischemic stroke rate was extraordinarily low, and this is just an unexplained finding. Despite the mean CHAD score being similar to these other trials, the ischemic arm was the warfarin arm had an extraordinarily low rate of ischemic strokes. And so to some extent, this may explain why the primary endpoint was not met in the PREVAIL trial. So ultimately, the FDA panel reconvened based on the presentation of the meta-analysis in October of 2014. There was unanimous approval for the device regarding safety, but efficacy was still unclear, and so they approved the device for a limited indication in March of 2015. And one last trial I will mention, in Europe, the trial was looked at in patients who have a contraindication to anticoagulation therapy, and these patients weren't treated with Coumadin post-implant. They were treated with just aspirin and Plavix for the short period of time that Coumadin is required after the implant. And they found that these patients in the ASAP trial, this is the expected stroke rate based on the CHAD score in this group, and this is the expected stroke rate if that group remained on Plavix, and this was the observed rate in the ASAP trial where they were implanted with the device and continued on aspirin and Plavix only for at most 6 months following implant. The limited indication the device is approved for is for patients with non-valvular atrial fibrillation with a CHADS-VAS score of greater than 2 or a CHADS score of greater than 1. Patients with a reasonable etiology for seeking a non-pharmacological alternative for stroke prevention therapy. Patients who can tolerate short-term anticoagulation because there is a short-term requirement of 45 days of Coumadin post-implant, and that the referral for WATCHMAN implant is part of a shared decision-making process. The logistics of the program at University of Maryland. Initial consultation of our referrals happens in a multidisciplinary clinic where myself and Dr. Vincent C. from electrophysiology and sometimes Dr. Murtaza Dawood from CT surgery evaluate these patients in a multi-D fashion. If patients are clinically appropriate for referral, they undergo a TEE to evaluate for anatomical appropriateness, and they undergo an anesthesia pre-op visit the same day. The device implant is then scheduled on a separate date under general anesthesia, TEE guided with 30 to 50 cc's of dye. Venous access is 14 French, and typically they're discharged the next day, and then we follow them up at 2 weeks, 6 months with a repeat TEE, 12 months, and then at 12 months. At 45 days, not at 6 months, at 45 days they undergo repeat TEE imaging to look at the device for adequate closure. The anticoagulation protocol that is stipulated by the way the device was studied is that post-WATCHMAN implant, patients remain on Coumadin plus 81 milligrams of aspirin for 45 days. After this, they undergo their TEE. If there's no thrombus and there is adequate closure documented, Coumadin is discontinued at that time. They then continue on aspirin and Plavix, full-dose aspirin for 45 days through 6 months, and then at 6 months they continue on full-dose aspirin lifelong. Turning the conversation over to cost analysis, $16 billion annually is spent on atrial fibrillation in the United States, and about half of that is spent on strokes that are associated with atrial fibrillation. And so in 2015, an analysis was performed comparing left atrial appendage occlusion with the WATCHMAN device versus Coumadin or NOACs for clinical effectiveness and cost effectiveness. And what they found, looking at quality of life data from the PROTECT-AF and PREVAIL trials, they found that patients who sustain a stroke after a WATCHMAN device sustain strokes that are less debilitating based on quality of life measures compared with patients on Coumadin and NOACs. They also performed this somewhat complex cost analysis looking at comparing left atrial appendage versus Coumadin, left atrial appendage occlusion versus Coumadin, and left atrial appendage occlusion versus NOACs. And what they find is that the time to clinical effectiveness when the efficacy of left atrial appendage occlusion and Coumadin is equivalent is at year 3. The time to cost effectiveness, where the upfront cost of device implant starts to be lower compared with the ongoing cost of Coumadin therapy, is around year 7, and the time to dominance, where device implant is more effective and less costly compared with Coumadin, is at year 10. With the NOACs, because they are more expensive, dominance occurs at year 5. And so here is the device arm, and you can see it crosses the NOAC arm at year 5 and the Coumadin arm at year 10. And so I'll talk about a case that we performed recently at the medical center. 69-year-old woman with paroxysmal AFib, coronary artery disease, and hypertension. She had a history of several months of hematuria, and despite extensive urologic workup, no definitive therapy or source was identified, but she had 2 significant bleeds on dual antiplatelet therapy and had been taken off of Coumadin due to this ongoing bleeding. Her CHADS-VAS score was 4 based on her gender, age, hypertension, and coronary artery disease. And she was also trialed on Coumadin and Xarelto and had failed both of those. Here is the left atrium. Here's the left atrial appendage with the device implanted there. Here's another look at the device implanted in the appendage with flow noted to not enter the appendage. And here's a close-up with a small peri-device leak. And this leak measures at about 2 millimeters. So we measure it at the vena contracta. And right here, the peri-device leak is about 2 millimeters. And so one important question that has come up with the WATCHMAN device is, what is the impact of peri-device leak when it's noted in follow-up or peri-procedurally? And as I mentioned, successful closure is defined as closure with less than 5 millimeters of peri-device leak. So looking at event rates in patients who have minor leak versus moderate leak and severe leak or no leak, there's really no pattern to their rate of ischemic stroke and systemic embolization, or all these events put together. And so the conclusion is minor leak or even moderate leak up to 3 millimeters has no real clinical significance in terms of future clinical events in these patients. The experience at University of Maryland, we've completed 9 cases here. All have been discharged the following day. They're watched for 1 day in our CCU. 7 of our 9 cases have completed their follow-up TEE, and all 7 have had adequate closure at follow-up. And this is our WATCHMAN team. The implanters are Dr. Vincent C., who's an electrophysiologist here at University of Maryland, and myself. Surgical backup is Dr. Murtaza Dawood, and Dr. Libin Wong is our imaging specialist who provides TEE guidance, and then our coordinators are listed here as well. In conclusion, the WATCHMAN device is our most rigorously studied left atrial appendage occlusion device. The appropriate population to benefit from device therapy, the optimal population to benefit remains to be fully defined, but in the right patient with bleeding risk and significant stroke risk, the WATCHMAN device is a great option to offer patients who are often otherwise undertreated for their AFib-related stroke risk. So thank you once again.